Good afternoon, guys. I've got your discussion aid for you. This afternoon, we're discussing integrating in home care for seamless transition from hospital to home. Okay, so we're going to get into that now. This concept centers on creating a tightly coordinated, person-centered bridge between hospital discharge and safe, supported recovery at home. It's not just about sending someone home with instructions, it's about orchestrating a symphony of uh, clinical, logistical, and social supports that anticipate risks, empower caregivers, and prevent avoidable uh, setbacks. Why it's transformative. Reduces fragmentation. Hospital discharge is often a cliff. Patients fall through gaps in care. Integration smooths that cliff into a ramp. Improves medication safety. Uh, Recalculation and simplification prevent errors, duplications, and adverse reactions. Empower caregivers. Training and culturally adapted materials reduces stress, increases confidence, cuts costs, and readmissions. Coordinated care reduces emergency visits, hospital uh, bounces, uh, bounce backs, and long term complications. Promotes equity when tailored to language, culture, and geography. It closes the gaps for marginalized populations. Key building blocks. Early discharge planning starts on admission, not on the day of discharge. Identifies home environments, caregiver capacity, and social risks. Real time communication. Secure, direct handoffs between hospital, primary care, home health, and community services. Home based clinical care, skilled nursing, therapy, wound care, and IV meds delivered at home, reducing travel and exposure. Medication management includes pharmacist review, pill organizers, digital reminders, and caregiver education. Caregiver supports, tech back methods, virtual guides, and culturally relevant training materials, home modifications, and tech ramps, grab bars, oxygen, and remote monitoring tools installed before discharge. Community wraparound services, transportation, meals, behavioral health, and peer support integrated into the care plan. Follow-up protocols, scheduled visits, telehealth check-ins, and symptom tracking within 72 hours of discharge, post-discharge. Build the plan. Align roles, schedules, services, and confirm logistics. Coordinate services, book visits, order equipment, and notify providers. Educate caregivers. Use plain language, visual, and cultural adapted materials. Transfer information. Send concise, actionable summaries to all post-discharge providers. Initiate follow-up. First contact within 24 to 72 hours to reinforce the plan. Monitor and adjust. Track symptoms, adherence, and social needs for 30 days. Matrix that matter. Category. Clinical, 30 days admission rate, ED visits, medication discrepancies, process, time to first home visit, med recalculation, completion equipment delivery, patient confidence scores, functional status, satisfaction. Surveys. Equity. Outcomes by race, language, income, or geography. Common pitfalls and how to fix them. Poor communication. Use shared templates, direct calls, and incorporate communication systems. Service delays, pre-book visits, and confirm delivery before discharge. Staffing gaps. Train cross-functional teams and use telehealth extend reach. Cultural mismatch. Co-design materials with communities and use trusted messages. Payment barriers. Engage case managers early and explore bundled or value-based materials. Then you have real-world examples. Imagine a 76-year-old man discharged after congestive heart failure. His hospital team begins discharge planning on day one. Before he leaves, they schedule a home visit within 48 hours. Average arrange a telehealth follow-up with his cardiologist and PCP within 7 days. Provide meds in a blister pack and train his spouse on weight monitoring. Deliver a scale and symptom tracking app. Contact him to connect him with local meal program to address food insecurity. This coordinated approach dramatically reduces his risk of readmission and improves his recovery experience. Okay, how to get started. Create standardized discharge checklists that includes home and social needs. Pilot rapid home visit for high-risk patients, e.g. CHF or COPD. Build partnerships with related home care and equipment vendors. Track a compact set of matrix weekly during rollouts. Co-design patient education materials with target communities. Would you like help drafting one-page checklist, a pilot protocol, or culturally adaptive toolkit? Rural seniors, I'd love to co-create something with you. Okay, guys, so that is your A. I'll be back on in a bit for B after I eat. So see everybody later for B.